Hi, guys. Welcome to Cutting Edge Health. And today we're talking about a topic that is a critical topic. It is the topic that has to deal with spine surgery and one of the major complications that can occur from it. And that is adjacent segment disease. Like always, we will break it down and explain to you. But for those of you who are joining us new to the channel and to this video, what we make sure that we help you do is understand your health, particular musculoskeletal, meaning kind of bone and muscular and joint issues, but also how that exists in the context of who you are as a person, your behavioral health, how it affects your mentation, how it affects your mood, how it affects the way that you process information cognitively, and how we can be able to give you the best outcome you possibly can to lead the best life that you deserve. So today, what we're going to talk about is this adjacent segmental disease. And I'm going to explain to you what that means, how you can be able to get context from that, and really the things that you need to know in order to be able to have an appropriate understanding of all of this. So at the end of the day, don't be afraid. We're going to make sure that this is exciting. And we're going to make sure that you get the full understanding, so it's not going to be too complicated, that you're going to get every last nook and cranny, and you could be able to get like, all right, this is what I got. So we're going to make sure you got all of it. All right. So first, let's kind of look at some pictures, because I think that's an easy way to start off with, so you can understand exactly what the heck I'm talking about. And then from there, we can be able to broker, what does this mean? How is it potentially impactful to you or someone that you care about? And we'll go forward from there. So let's take a look at some lumbar fusion type pictures, but let me just kind of set the stage. As we look at these pictures, we can see that there's bones, and we're looking at the spine in a profile view. So for those of you who haven't seen that before, kind of let me take a step back from that picture for just a second. So, and show you this on a model, so that way you can understand exactly what I'm talking about. So let's say that you're looking at a model like this, right? This is a spine. This is as if we were staring at one another, kind of straightforward, right? But then if I were to turn to the side, you can see that this is a lateral view, right? So it's a profile kind of view, right? Or sagittal view is what we use if we're saying it in fancy terminology. Well, that sagittal view is what you're looking at in these pictures. So what you're going to see, particularly in the lumbar spine, is hardware or instrumentation coming in from the back, where this would be the skin, and you can see these various different screws and rods, similar to where my finger is, going into the areas of the bone. And what I want you to pay particular attention to is not just the area of where the vertebral body is, where the hardware is, but the levels above and below, hence the name adjacent. So it's the nearby area. So let's show you that picture again. So as we take a look at this picture, you can see on the first picture on the left-hand side, the area of a spine. And one of the reasons why we're kind of really taking a look at this is because you can see there's a little slippage or step off between the L5 and the S1 area. But be that as it may, you can see that there's these screws and rods that are coming in, and they're coming in through the pedicle to be able to provide some degree of improvement. And what we're going to be looking at over the next couple pictures is, how does this relate to the level above it or below where your rods or screws are? So let's take a look at a different picture that can give us better clarity of that. So let's say you take a look at this picture, and you can see there's some differences in the screws and the spacers in between and all those type of things. But at one point in time, you can see there's a wide open space that's in between. And then you take a look and you can see in the circle, there's a difference where there's a narrowing that's present of the disc, and more than likely a concomitant narrowing of where the nerve roots have to exit out from. So shown in kind of 3 dimensions again, if you imagine that you had hardware that was in place here, then below it, the level below, is where you see this potential change that takes place. So what does that mean? So what that means is that occasionally a surgery that's done for a fusion can cause problems above or below where the surgery was done. So let me repeat this again, that the surgery that was done in order to be able to improve back pain or improve function, occasionally there can be a change above or below. Now notice there's a qualifier there saying occasionally. We're going to talk about that, define that so you can get some understanding about it. For those of you who are joining us live, by all means, pitch questions, because your questions are what's going to help us be able to answer everyone's questions who might have something, and we'll be able to kind of move that forward and answer things as we kind of go about. But what you need to understand is we're going to start off with a simple topic of saying Maybe fusion can help at times, although most people don't want a fusion, and who would if you could be able to avoid it? But what we really need to understand is if you have risk factors and there are things that potentially lead you to have this adjacent segment problem, right? What sometimes then happens is you're faced with a difficult choice. You're faced with a problem that occurs that may be very similar to what you had prior to the surgery. And it may also require for you to have another subsequent surgery. And so this is where things get really complicated real quick, where patients are like, man, I just had a fusion and now I have to have a second or a third. Well, this should be a topic that should be discussed with a little bit more degree of frequency, in my opinion. And it's one of the reasons why we're having this conversation today. So let's take a look at spine surgery in general, and then we'll kind of back out and come back to this in just a little bit. All right. So when you take a look at spine surgeries from the last 10, 15 years or so, you can see fusions actually dominate other spine surgeries, that they are more prolific than what's present for discectomies. They're more prolific and more prominent than what you have for interspinous devices that are in place. They're certainly more prevalent than spinal decompression and all the other different types of procedures that are in place. So fusions really kind of dominate the landscape. And actually, there's an article looked at that was actually from the Washington Post that stated or had questions about why are spine fusion rates continuing to increase. And what it showed is a couple of different graphs. One, and although this is a little bit dated, it's almost a decade old, the fact of the matter is these numbers haven't been decreasing. So the cost per surgery has tripled. But the fact of the matter is, when we look at the medical supplies that are in association with it, it hasn't kept the same type of pace. If you can see that you have this 12,000 and 40,000 at one point in time, now you can see a 50 and 111,000. And there's a pretty decent gap, as you kind of be able to imagine. So there's some thoughts about the financial drivers of this. It doesn't necessarily mean that surgeries are being done with no degree of clinical evidence or reason for doing it. But you really want to tap into your doctor, have questions between both your surgeon, your primary care doctor, and maybe even have maybe more than one opinion to kind of get some assessment of that. But the number of surgeries have not just increased linearly, but they've increased exponentially. So if you can take a look from the areas of 1992 to 2012, there's been a huge increase in terms of the number of surgeries that have taken place. And that degree of change, some would say it's because there's a portion of looking at, well, there's new technology that's been brought into place. There's different approaches that can be utilized. And to an extent, that is indeed true. However, what we really are kind of trying to be able to assess is, yeah, but are there consequences behind doing those type of procedures that end up resulting in not maybe the necessarily best outcome for patients? So when that occurs, what we really need to do is maybe kind of take a step back and say, perhaps we can be able to offer other therapies that can be able to give benefit that aren't necessarily reliant upon just a true surgical instrumentation and intervention of that accord, right? So going on, let's kind of take a look at the elements of this adjacent segmental disease that's in place. So this cartoon shows a fusion surgery that's in place on the left-hand side. You can see there's a cage or spacer in between, like we saw in some of those radiographs. And what you do want is you want this fusion to take place. That's what you're hoping for, right? This fusion is supposed to take place in this area. But what ends up sometimes occurring is the change that's present, where you can see this blue above becomes narrowed and it becomes squeezing and it becomes degenerative disc disease. And the reason why that's important is that actually squeezes where some of the nerve roots are. And that can be incredibly challenging. And a lot of people will say, well, you know, it's natural to have degenerative disc disease, and it certainly may be, but you can see those changes that take place, and they're much more prevalent in and around that area of the fusion. So why does that occur? There's a number of different speculations as to why it occurs, but the plain and simple fact of the matter is there's a couple different things that are in place. One is there's hypermobility that's in place from the fusion. Two is that there's some association with ages, both the person ages as well as the fusion ages. But three is the area of biomechanical differences that exists. And so those biomechanical differences that exist basically mean that that spine normally moves in a certain way. And then when you introduce the areas of that change with the hardware, you can be able to see that there's differences in terms of how the body relates from one segment to the other. I think there's a question, so let me see, or maybe there's a statement. So from one of our viewers, we really do appreciate you guys joining us and asking questions. I had an MRI just before COVID and appears my fusion failed. Is this going to be something I could do in place of surgery? So before we kind of get into different therapeutic options, which obviously for each individual person, we're going to talk about those things offline and not within the context of everyone else. One, to be able to protect your information. And two, because what might be pertinent for you may not necessarily be pertinent for everyone. But we'll give different options that you can look at, things that you can do post-fusions, things that you can do prior to fusion that may be able to help you. And we'll kind of talk about that. But right now, we want you to understand exactly what this is and how it can be impactful to you and when might be more likely that you may have something like this than someone else, right? So going on, one of the things that we want to kind of give context to is not every fusion is done in the back. Sometimes it's done in the neck. So this schematic represents the cervical region or the area in and around the neck. And for the most part, when you have a surgical fusion, you have that hardware that's placed in the front of the neck, in the front areas of the bone. And what ends up resulting is that you can have changes in that area of the disc, which most frequently, as you can see from this cartoon, represent different things like a disc bulge back towards the areas of the cord and nerves that are in place. So you can have a surgical fusion that improves some things, but they can cause different problems in another location. So as you guys know, one of the things that I really want people who are viewing our channel to understand is that you can be able to go back and find this information for yourself. And so we want to make sure that we give you literature that you can look at and you can Google it. You don't need a fancy degree or letters behind your name to find this. You can go Google this and go to PubMed and have access for finding articles that give you this information. And every article in all of the talks that are on our channel are all free access articles, meaning you can see the entire thing. You don't have to pay anything for the PDF, and you can be able to see the original research for yourself and what are the conclusions, what are the results, and how they did the studies. So that way you can say, yeah, I get this. And one of the reasons why we do this is because a number of patients come in and say, oh, you know, our doctor told us that there was no literature, there was no support for this, there's no value into this. And I'm like, that's not true. But I don't need for you to take my word for it. I want you to go find it for yourself. So then you can compare and contrast, and you might not even be in our locale. You may be someplace else, but you can show it to your doctor and you can be able to say, hey, there's actually stuff that's here. And I want you to give me your medical understanding of whether this is contextual and it makes sense or not. Okay. But be that as it may, what we're going to do is we're going to start talking about a couple different articles that show information about this and explain it a little bit more. But before we do that, what we're going to look at is the following is, so when we take a look at spinal fusions, there's sometimes a little bit more prevalence of fusions in certain areas than not. So if you can see, the top line area is those that are getting an original fusion. The vast majority typically tend to be lumbar at 51%. And then the areas that's the second runner up is in the neck or the cervical, that kind of lighter coloration. And then in the middle, which is a very small amount, is the thoracic region. And so those that have actually refusion or needing subsequent procedures, you can see actually there's quite a few in the lumbar region. And then you can see there's quite a few actually relative to where it was before that are present in the thoracic region. You can see there's a little bit less than what we might expect in the cervical region. And one of the reasons why I put that slide in is historically, you can see that most of the problems don't necessarily occur in the low back, which for many patients that have had a low back fusion, which typically tend to be more numerous than not, normally you may not have a problem. But what we're seeing is that because there's more people who've had lumbar fusions, that they may end up suffering a problem such as this and might be a subsequent surgical candidate, right? And don't forget, I know that there was a question asked earlier about, well, what else could we do other than surgery? And it wasn't necessarily just in the context of adjacent segment disease, but we're going to talk about that, okay? So let's look at our first article. So our first article is adjacent segment disease in incidental segmental fused vertebrae, a comparison with the effect of stabilization systems on ASD. I know it's a lot of fancy terms. I get it. I know it certainly seems daunting, but as you know, this is what we're going to do. So we're going to make sure that you get what it is that the basic gist is, so you can understand what the premise is, what it means, and really why it matters. Okay. So let's take one simple line from it, and then we're going to use this to kind of construct our understanding of the problem. So adjacent segment disease is a controversial process after spine stabilization, which we've already kind of established. And there are two important factors that are discussed within the context of this particular article, which is natural aging and hypermobility. And so those things can predispose you to having different problems. Well, one of the things with that is the hypermobility sometimes is very difficult to predict despite various measures that you can do. And we're all going to age. So although there's a context of how old you start from when you have this fusion to when it gives you a problem, the element of it not giving you a problem at some point in time is a little bit challenging. And there might be a reason for why you may want to look at doing other therapies instead of doing a fusion if it makes sense. So what this particular article showed was that the highest rate of incidental fusions were present within the cervical region, and then the thoracic, and then the lumbar region, which is different from that picture that we showed. But what they saw is that adjacent segment discs can have issues at any age with any type of fusion, and hypermobility can play a role, but it's not the only role, right? So one of the articles that they show, one of the graphs that they show is what are the areas that seem to give most of the problems. And the area at C2, C3 is probably one of the most prominent regions because it has a lot of mobility. So if we're going back to kind of our trusty little spine to kind of take a look, it's that area that's higher up in the area in and around where the skull happens to be, right? And why is that? Because you have a lot of mobility in that area, in that region, going back to that same spot. Hence, there's a reason for why not too many fusions are done in that area, but be that as it may, that's one of the contexts. The second is in the thoracic region, which again, if you recall, there's very few fusions that are done in the thoracic region. There's some reasons for why that is. And one of it is because it can result in problems and issues. So that area is in the upper area of the thoracic region, which seldom do you see many fusions done. And then the third and final that kind of is that uptick is the area around T12 and L1. So that's the area in between that low back and the thoracic region. I guess the question would be, so why am I telling you all this? The reason why I'm telling you all this is the following. Is when you have a problem and your MRI comes back and you talk to your doctor and they say, hey, it looks like you got a problem at C23, or you got a problem at T34, you got a problem at T12L1, where these different junctures are, and there's a lot of degree of mobility. Before you start talking about a surgical indication, that's when you really might want to say, you know what? How else can I be able to treat this in a conservative fashion? Is there another way that might make sense that really can be able to help stave off some of these problems? Looks like we got another question that's possibly coming in. Okay, so let's see. Would it be beneficial to focus on the nerves that send pain signals to the brain that you're in pain? So yes, it certainly could be. Obviously, I have a number of viewers and patients that are really on top of it. I appreciate you guys watching our channel, and hopefully we have a role in helping you be able to garner some of that information. I think that there's value that's there, clearly, because that's some of the things that we do. But the other thing that I would say about that is that perhaps influencing the structure without introducing hardware that keeps the biomechanical advantage, meaning you don't change and limit how one segment relates to another, may be the ideal setting if you can. Or if you're going to do it, that you limit the degree of difference between one area versus the other, so that physics works with you as opposed to against you. So continuing and going on, one of the things that they did was there's another article that is the following: incidence and risk factors of reoperation in patients with adjacent segment disease and meta-analysis. And so I obviously can see the literature and the reference that's present here. For those of you guys who want to copy it down or take a screenshot, by all means do so. But at the end of the day, you guys know we've talked about meta-analyses before. They are what takes place when you take a number of research articles and you compile them, meaning you put them together and you look and see, okay, it's not just one paper, but it's multiple papers. And what we're trying to see, is there a unifying theme? Are there things that researchers in one area of the world found in another area of the world? Were there similarities in a place that had a center trial that had it done in a lot of different locations versus a small case series that might have been done at one hospital? What are the things that seem to come up over and over again? And again, kind of going back to our picture type theme, what we were able to see is the following, is that when you take a look at this picture, is that what they saw was increases of degree of problems as the person was getting older. And I know that's probably not something that's all that outside of common sense, but having the validation of the research from multiple research articles to show that is kind of important. So what is the age where things start to get a little bit tricky? Well, anywhere between the ages of 55 up to the areas around 70 or so. That's where things start to get problematic, right? Of how well a fusion might not work. And so as you either fall within that group or you start getting closer to that group, you may want to say, I don't know if I necessarily want to pursue that. Ironically enough, many of the fusions are done within that area, so within that age frame. So I know there's a context of like, statistically, does this make sense? But when you take and they looked at and analyzed this across multiple different studies, they saw that really that age group was probably one of the higher risks for having problems. And the second thing in this particular article is they found the following, and that is the longer the fusion length was, the more problems resulted. So what does that mean? So what that means is if we were to take a look again at that spine model, right? And you said, okay, well, we're just going to cover a couple levels versus we're going to cover the whole expanse of the lumbar region, it's more likely that you're going to have an adjacent segment disease problem that's going to be on the borders. And I guess many people would say, well, why is that? Well, one of the reasons why is because that increase in length is going to definitely change the biomechanical pieces of how the spine functions and make it even more stark in relationship to how that segment that's next to it is going to then function in comparison. So preferably, you would want to have a shorter fusion. Now, most patients don't come in and order this like on a menu and say, hey, you know what? I want to have only a 2-level fusion. I don't want a 5-level fusion. No, many times the doc is the person who's telling you, this is what you need, right? I think the thing in this context is to get some understanding about what's going on, what's predicating the fusion. Is it based off of pain? Is it based off of weakness? Is it based off possible progression and how things may advance? And I think those are the questions that you need to be armed with. And that's really what we want to kind of give patients, is not so much to make this a contentious relationship with the surgical colleague, but more so being able to have the ability to be your own advocate. How can you be able to say, you know what, I'm going to walk in here and I want to have answers to my questions because it helps me make an informed decision. And I think that's what you really want to kind of look at. The rest of this article kind of goes into some depth and detail, but at the end of the day, what they basically say is that there's a number of different risk factors if you look at the last 3 lines. And these are things that I think are pretty important. And one is that if you're over that age of 55 years or older, if you have a fusion at S1 or you're somewhere between that T5 and T12, meaning again, that thoracic region that has a change that's greater than 40 degrees, if you have low bone mineral density, so for those of you who know that you can have osteoporosis or osteopenia, you can have problems and issues that are associated with it. And then finally, if you have something that's called a sagittal vertical axis difference, it's one of the measurements of the spine to see how it relates in relation that many times the spine surgeons are looking at to make sure there's not going to be a problem. There's a couple other risk factors as well. And I know I'm going through this really fast, but we're going to summarize those risk factors and then how you can be able to improve some of those things. So don't get too concerned about me kind of going through this quickly because we're going to cover this a few times. The other is a potential change in the thoracic bend if you happen to be of male sex. But there have been some other studies that have kind of said the opposite. If there's actually female gender, if you have pedicle screws, and if you have a fusion to lumbar levels below L2. All right, I think we got some questions coming in fast and furious, and I really like that. So let's see if we can answer some of those that are being posed. All right. Does or would acupuncture have a place in addressing or be a possible solution to pain involved, or is this probably just kind of like, is this fact or fiction? So first, I think we're dealing with different things. When I see this question, it's a question to me that talks about the pain itself, right? And we're less talking about structure. Right now, we're talking about structural things that result in pain. So can you be able to leave pain that are associated with those structural problems? You can. But what I would say, again, is if we can be able to make the structure issues less, then maybe we have the downstream effect of pain being less. And I think that those things kind of matter. Now, if you're past a point, or if that's just not simply an option, to be able to deploy strategies that can be able to give good, efficacious, in essence, effective pain relief that's safe and that's sustainable over a period of time, why wouldn't you consider doing that? And by the way, Jesse, I know that you were just asking for a friend, but we want to make sure that we're answering that question across the board for everybody. Okay. So going back to our talk, one of the things that we mentioned was all the different risk factors that are in place. And in that particular paper, what they were able to say is that about 8% of patients had a reoperation rate due to adjacent segmental disease. And so this is where things kind of pop up. So there's been a whole host of different papers that say that the likelihood of it occurring after fusion can be as low as 5% to sometimes as high as 15%. And this is where there becomes a battle royale about, no, it doesn't happen as frequently, or no, it doesn't happen at all. Let's say we took the average and we said 10%. I think if you told most patients you got a 1 in 10 chance that this back surgery you're having, you might have to go back again, that makes things a little dicey. Because most patients I know aren't too thrilled about getting a back surgery to begin with, unless they're in dire pain and dire problems with mobility. But at the end of the day, to know that you have the likelihood of having a recurrent surgery and maybe another recurrent surgery thereafter, because these are things can be additive, can be a bit of a challenge. And so I think it's something that patients should know, that it might be 5%, but it might be 15%. And that becomes a huge problem when we really start to kind of evaluate some of these things, right? So let's take a look at risk factors and kind of give a summation, and then we'll come back to this again at the end of the talk. So one of the things that we know can be a problem is age. That certainly can be much more likely that you have this type of problem. The second can be is if you already have disc degeneration in the areas around the fusion before you even do the fusion. So if you know that you have narrowing that's present, and I think the elements of saying disc degeneration, it scares a lot of people because they think that the discs themselves that are in between the areas of the bone, right, are starting to kind of crumble to dust and it's just disintegrating. That's not necessarily the case. There's actually a grading scale for disc degeneration. We talked about it in one of the other YouTube videos. So if you haven't watched that video, go check it out because it will explain things pretty darn well. But be that as it may, so it just matters that you have a little bit of change, and that change can predispose you to having potential problems. Gender can make a difference. And one of the papers says male, one of the papers say female, but at the end of the day, what the heck, we know that we can be able to get this problem. But the other things are if you have facet problems, which we've talked about what facets are, but just to reiterate for those of you who may not have seen some of those talks, what we're talking about are the joints that let you be able to bend and twist and turn. And many people, I say most people, have some degree of arthritis, and that can start pretty early actually in life. It's not necessarily equated to you having to be in the 5th or 6th decade. Many people have arthritis much sooner. So if you know from your imaging you have arthritis and you know that you might have osteoporosis or thinning of the bone, this is where things start to become problematic. If you're a smoker, if you have less physical activity, those things kind of set you up for not a good outcome. If you have, as stated before, a large number of fusion segments, if you have different types of way that it's performed, and if you have some things that are issues with sagittal alignment or floating fusion, those things can definitely predispose you to having this problem. So again, we're talking about the aspect of adjacent segmental disease. It's quite the mouthful. I know it is, and I understand that. But at the end of the day, kind of summarizing a simple version, it's you had surgery at one portion of your back, and now it's causing you a problem above and below it. And if that's the case, we really want to kind of prevent that from getting worse. And hopefully you can be able to prevent it from happening in the first place. All right, so let's move on to another article that kind of gives us a little bit of information. Hang in there with me, guys. We don't have a heck of a whole lot of many other articles. As a matter of fact, this might be our last, that looks at risk factors for adjacent segment degeneration after posterior lumbar fusion and treatment of degenerative lumbar disorders, a meta-analysis. I know a lot of people are like, why we keep picking these meta-analysis? And the reason why is because you can get a summation of a lot of different studies. You can get a lot of information and use that information to make your best hypothesis, a best educated guess, right? So this paper, what it ended up showing is the following, is that they looked at 19 studies and they found that the rate of adjacent segmental disease in their analysis of about 540 out of 2,896 procedures was that it was 18.6%. If you remember, I quoted that number of 5 to 15. So they had a much higher number. And I think that, again, the surgical data is really skewed across that. But what we can see is that areas of older age, what they found and wasn't mentioned in some of our other studies is body mass index. And so kind of it's not quite the same, but your overall weight can have an impact, both pre as well as post. So making sure that you're within your weight limits that you would probably be deemed appropriate is going to give you a much better outcome when we start talking about surgical fusions and how we're looking for not having a problem above or below it. The addition of being able to avoid smoking as well as high blood pressure, those things are key. If you have disc degeneration prior to actually having the surgery, the length of the fusion, if you have that facet joint or arthritis that's present there, and then various different measures that can give you issues that are kind of the angles and other portions that are in the spine. So I think we've covered adjacent segment disease really well and in depth. We're going to kind of go back through some of those risk factors and kind of then talk a little bit about how you can be able to deal with those risk factors, how you can be able to kind of get after it, and also some potential treatments that exist out there in both allopathic and non-allopathic circles. So let's take a look again at this picture. We can see that the area of the fusion with the cage that's in place, and we can now see pretty clearly within that area of that circle, that narrowing that takes place, right? And so when we have that narrowing, that's the thing that we're trying to avoid because it can cause all kinds of problems and issues. So again, what are some of the risk factors for it? Risk factors are the following. Like I showed once before, age issues, if you have disc degeneration prior to, if you have arthritis is present in the back, if you have osteoporosis, if you have smoking, if you have low physical activity, if you have a pretty sizable fusion that is going across multiple levels, it certainly can give you an issue. And depending on the type of surgery and how it's actually being performed, it can also give you a problem. All right, so with all that, now let's kind of talk about what are some of the preventative strategies, as well as what are some of the other things that you can do in lieu possibly of a fusion to be able to get some degree of benefit, right? So let's give you context. When we take a look at this, what we really want to be able to say is, all right, let's understand what the imaging shows prior to the fusion. Can we be able to look and get a good understanding of, is there disc degeneration even prior to doing the fusion? Are there herniated discs? Are there narrowings? Is there squeezing that's taking place? Is there spinal stenosis? We cover a lot of this on our YouTube channel, but you can find this by taking a look throughout the web and online to get better understanding of this, right? And then let's put this with poignant, targeted questions when you pose this to a surgeon or your doctor who might make a recommendation. Make no mistake, I've sent patients for fusions for sure, and I've had tons of patients get better from it. But if we have the option to be able to do other things prior to fusion, why would we not? Historically, we've talked about doing different things like corticosteroids where you inject, but some small number of studies, not necessarily super high powered, have suggested by doing steroids, maybe we actually even increase the risk for this problem down the line. I think that corollary has been a little bit tenuous. It's not necessarily really robust, meaning that it looks a little weak. What some of that is being suggested. But at the end of the day, what we want to do is how can we be able to provide benefit? So one, easy stuff that we're going to talk about dealing, well, kind of easy, but it's more habit, right? Is one, can we be able to deal with smoking? If you're a smoker, you're not doing yourself any favors. We've talked about this before. There's a lot of different reasons from wound healing to lung stuff. But at the end of the day, it's potentially causing the same pain that you have to be worse. And the treatments that we're going to try to do they're going to be less likely to work, and they're going to be potentially giving you a problem. Now, I understand very good and well that smoking can be a stress reliever. It can be able to help you get through the pain that's giving you all the problems for you to say, man, I can't do all the stuff that I want to. And it lets you be able to get some of that off of you, right? But when we're talking about surgery and you're having a fusion or someone's going into your back, it would be a really wise idea to see if you can not only stop smoking for the surgery, but indefinitely. And I have a number of patients that have said, all right, I'll quit for the surgery and I'll get right back into it, or I'll decrease it and I'll see what I can do to try to be able to not stay, not to get back to smoking too soon. But what really the theory should be is not returning back at all. If you're older, is saying, okay, what else could we do? And so what are some of the things we could do, which I think was one of the questions that was posed earlier. So one of the questions that you can do is to see, can you be able to improve the structure of your back? Can you do it through prolotherapy? Can you do it through orthobiologics? And those are regenerative medicine type techniques that can try to be able to provide strength, increase integrity and the tensile strength of things like ligaments, to try to be able to improve cartilage, to try to be able to improve what's going on with the disc. So that way you don't have to have these instrumented areas that change the biomechanical movement and advantage of what's going on in the spine. So that'd probably be kind of hand in hand too. 3 is, as you can see, there was commentary about physical activity. And if you're not active and you are sedentary, then muscles in and around the spine are in some ways deconditioned. And when they're deconditioned, it doesn't present the best option for how the spine is going to respond, because you just don't have the structure to really be able to support this as well as what you would otherwise hope. In relationship to that physical activity, which is not always that easy to do. I get it. I talk to tons of patients about this, but if you can be able to increase your physical activity, increase your physical load, it may be able to stave off some of those problems. Most of the reason why people can't be able to do it is because they always already hurt. So if you're hurting, how do you take that hurting to now then be able to circumvent that completely? So now you can do exercise when you're just trying to be functional. I know that that's a conundrum. I certainly get that that's a challenge, but if there are ways for you to be able to use either distraction techniques, for you to use different type of stretching or meditation to be able to get into that place, I think that may be something that would be prudent for you to bring into your otherwise strategies of trying to be able to deal with the pain and how to be able to use exercise to get it better from that context. Then what I would say is, if you're having problems with the disc above and below, or you have a problem with the bone, one of the things that has been postulated is, can you make that native area, whether it's the disc or whether it's the bone, stronger, more rigid in some ways by either doing vertebroplasty or things of that ilk? I think there's some value to it, but I don't think the literature has shown it definitively. What I would probably say is, let's see what that bone marrow is like. Let's see what that disc is like. And then, is an orthobiologic treatment really warranted? Why? Because you're not changing the natural construct. You're providing a supple response of what's going on with the area of the tissue. And hopefully you're able to stave off downstream sequelae because you've been able to either halt it or maybe be able to reverse it to an extent. So those are some of the things that you can do from a regen standpoint to be able to improve the problem. Many of the questions that came up were questions that centered around how to be able to deal with the pain that might be associated with it. There's a number of strategies that are out there. Historically, we've used neuromodulation, particularly in the neuraxial spine. So let me not be fancy. Let me make sure I'm breaking this down like a 5-year-old. So what that means in regular, just layman's terms, is instead of us talking about neuromodulation, we're talking about doing a spinal cord stim within the area of the back to try to see if we can improve this problem. There's really a kind of fancy medical term for something like this, and it's called post-laminectomy syndrome, particularly within that context of fusion that has failed. But at the end of the day, really what we're trying to be able to do is to see if we can be able to treat the pain. And spinal cord stimulation can be able to provide value, both traditional as well as dorsal root ganglion stimulation, which we have videos about both that can help explain to you so you can understand exactly what that means. Okay. So I think that there's a number of different ways to be able to try and take those risk factors, decrease them and their likelihood of giving you a problem, and finding ways to be able to be innovative and hopefully be able to be preventative so you don't have problems and issues. Okay, let's see. In the past, the health department has had programs to help people to quit smoking if help was needed. I think that's phenomenal. I think people can be able to look to their primary care doctor. They can look towards other services that can help them with that. And I think by being able to stop that, it gives you a heck of a chance to be able to have a better outcome. So today, what we talked about was this adjacent segment disease, how the problem can occur next to a fusion because of the changes biomechanically that exist, and how that can then precipitate its own other need for surgery, which we don't want to have this be this caterpillar type deal where things seem to continue to progress until you have nothing there but sides fusion throughout the areas of the back. What we want to do is to see, can we be able to do other things structurally? And if we can't, can we be able to improve pain without us having a need to do multiple surgeries? Thank you so much for those of you who have joined us. And also thank you to those of you who are joining us at a later date. If you have questions or you have concerns, please sign up for our newsletter and shoot them through the online portal so we can be able to answer those questions. And what I would hope that you can be able to do is to figure out a way so that whatever strategy you use, you can be able to figure out how to punch pain in the face and get back to leading the life that you deserve. Thank you so much and have a great day.